folks here today. Just in case you didn't know, I don't see them. Tom Isbell and E.T., or as you guys know, Mike Ellis is the new training officers for there. So you'll see them popping in and out. And some of their folks wanted to join today, so we're happy to have them. This is also being recorded. She's recording, and it's not live. She's just recording it so they can show it again later. So we're thankful to have that resource and appreciate Prisma coordinating with us on that. So we're going to let Christina introduce our speakers.
Sounds
and
good.
Get started. Christina is the STEMI coordinator here at Prisma.
So yes, I am Christina Freeman. I am the STEMI coordinator at Prisma Health Upstate. So if you have any questions that I can help you with, I'm Christina.Freeman2. If you don't add the 2, you're talking to a physical therapist in the Midlands who is pediatric. She doesn't know what you're talking about. So please remember to add the 2. But if there's anything I can do to help you, I do those feedback forms that get sent to your leaders and educators. But if I'm a little delayed on that for some reason and there's a case that's weighing heavy on your heart, feel free to reach out to me. I'll be glad to take a quick look and give you an update. Anything else I can help you with? Please, I am not a manager of people, I'm a manager of processes. But it is my job to put out the fires, and I try to put out the fires when they occur so they don't turn into something that repeats. So if there's an issue that you would like me to know about, there's some piece that didn't go well, that's on the Prisma side or something I can help with communication, please let me know in as real time as possible so that I can get on it. Because I always say I have a boss, I have a medical director, and I have an administrator, but I work for you. So let me know what I can do for you. I'm pleased to bring our friend Steve Watson from Zoll today. He's going to have a couple of slides at the beginning of our presentation. And when Steve is done, we're going to turn it over to Dr. Craig Hudak. I know you all know Dr. Hudak. He has been my medical director since I took this position. He was here before me. He is the medical director for STEMI and chest pain. He's in the process of turning that over to a new medical director, and I'm very sad to lose him, but he's such a great educator, and he agreed to repeat this for us today. So he will be talking to you on Pressors in Prehospital Medicine. Received great feedback on this when he presented it at EMS Night back in, I think, May.
Yeah, it was months ago now, yeah.
So I didn't change, I changed the date, but I noticed when we got here I didn't change it from night to day. So welcome to day. All right, so first Stephen, and then we'll turn it over to Dr. Hudak. Thank you all so much.
Thank you, Christina. Good morning, everyone. My name's Stephen Watson. I'm with Zoll. And how many of you are familiar with Zoll and used our products? Good, that's awesome. Very, very good. As you know, Zoll's a huge company. We're a big company, and we're certainly invested in you, and we're certainly trying to make products that are best for you on the front lines. And we certainly appreciate everything that y'all do. As you can see, these are a list of our different products that we're in the different markets that we're in, and we're ever expanding. So for you guys, for EMS, I think probably well, I didn't know what slide was first, but this is LifeVest. So LifeVest is my product, and I'm the local rep. So we have a lot of different reps within all the different Zoll divisions. We don't have one in every market. So if there's any Zoll questions, any Zoll problems, you can always call me, and I can filter it to whomever that particular rep that is responsible for that particular product. LifeVest has been around for about 10, 15 years now. About the only thing that we ask with the LifeVest, if you do encounter a patient that has one on it, is just please don't cut the cords. The LifeVest will actually disengage really easily in the front. It just has 2 little tabs, and then we just ask you that you will need to disengage from the monitor, otherwise it'll beep like crazy. But most of our patients typically are alert and awake after they've been treated with the LifeVest, so it's not often that EMS is called. We typically call the patients immediately once they've been treated. We try to get them to go to the hospital, but you'd be amazed the patients that don't always want to go. So, but the LifeVest, it's a real simple device. If you unlatch it, you'll be able to have full exposure to the chest, and then just unplug the device. But the only thing is we just ask, please don't cut. If you do, it is what it is, but we'd like to reuse these as well. Let's see what else we got. It's been a while since I looked at these. So here are a list of a couple of the products that look at what you guys are familiar with. We got the X series. The Zoll AED3 will give you CPR feedback, which is one of our newer features. I'm not sure if you guys have experienced that. I'm not an expert on our AEDs, but it will give you CPR feedback to let you know if your chest compressions are too shallow or too deep. or too fast or too slow. So it is a helpful device. Our data division is growing ever extensively as well. So if you're having data struggles or communication, that's something that we could also entertain as well. Let's see, and that's pretty much the new portfolio products. Y'all use the X series, correct? Okay, perfect. If y'all have any problems, any questions, or anything that you need to know about the X series, or if y'all need a new in-service or anything that I can connect you with our reps, that's probably my primary goal, is to make sure that y'all are getting what you need. And if please, you can speak up and say, well, I don't like it, or this, that, and the other, but and we're always trying to make them better. All right, lastly, let's see. Yeah, so here's our different our territory managers. As you can see, I'm here. Here's my phone number. It's a Charlotte number, but I do live here in Greenville. So if you do need anything in the Greenville market, you can always call me, and I can certainly disseminate it out. Grant actually is not going to be doing that anymore. He's moving into a new position, but Michael Cox has been on the EMS side for a long, long time, and he's a great rep. So these are the names and numbers. If you need help, please give us a call. We'd love to help you out. And if there's anything we can do, we're always willing to try. All right? Any questions? I told you to be quick, Dr. Hudak.
Good. That's all right.
Well, thank you so much. Again, we greatly appreciate everything that y'all do as first responders. And if there's anything Zoll can do to help, just let us know. Okay? Thanks, y'all. Have a good day.
All right. Thanks for being here. Good. Let's see. So, again, Christine introduced me. I know many of you. I like to keep these talks informal, so if there's something that you're wondering about, don't hesitate to interrupt. Okay, the talk's for you, not for me. So if you have a question, please ask. Yeah, so so it was June, I guess, huh? It was June. And I think you changed the date because the initial date for that talk was like April a year ago, and we got bamboozled by COVID. So here it is, 15 April. I kind of left it up there just because, kind of like a memorial to that day that died. Crazy. But we had a great time. I wish you guys were there. You should have been there. We were at What Ails You pub, and we had some great beer and food, and now we're just coffee and Diet Pepsi just doesn't quite make it. So I was asked to talk about pressors. So I'm going to take a pretty broad view of that topic. At the time when I made up this talk, I wasn't aware of actually which pressors you have available, and so we're going to talk about some things that you don't have on the trucks, but or don't have access to. But I think it's worthwhile thinking about that a little bit, even knowing the other agents. So first of all, I want to make a distinction just for your own benefit between pressors, vasopressors, and inotropes. Vasopressors cause vasoconstriction. And accordingly, they will elevate what we call the systemic vascular resistance, and we'll get back to that in a couple ways in a little bit. And that's one way to try to increase your mean arterial pressure. The inotropes actually don't affect the resistance directly. They can affect it indirectly, but they increase your cardiac contractility. So you've got basically two ways to try to increase blood pressure. You're either going to increase that resistance through the circuit, or you're going to increase the amount of flow through the circuit by increasing cardiac contractility. And again, some of these medicines actually will do both, as you'll see. So, I often tell people that, one of the reasons I went into cardiology in the first place is because you can readily translate some physical principles to what we see every day in the cath lab, actually. Okay, and if you remember back to high school, if you ever took physics, if you ever, voltage equals current times resistance. Does anybody remember that at all? That was probably ancient history for most of us. It's ancient history for me, but it's still worthwhile thinking about. You can make an analogy between voltage, which is a drop in potential, electric potential, to the changes in pressures. Okay, a drop in pressure, blood pressure across a system. You can make an analogy between electrical current and cardiac output. Okay, blood that's being going through the system. And then the resistance, you've got a resistance in an electrical circuit, but you've also got resistance in a vascular circuit. So you can make those analogies. So roughly, and I'm making some approximations here, the mean arterial pressure is going to be directly related to the cardiac output and the systemic vascular resistance. So you can there's two ways to increase the pressure, the mean arterial pressure, right? like we talked about. You can increase the cardiac output, or you can increase systemic vascular resistance. Remember that cardiac output is a product of the heart rate and the stroke volume, and agents can affect both of those. So to talk about these agents, we have to talk a little bit about some physiology, okay? And when I talk about physiology, I'm talking about the adrenergic receptors in particular. And I don't want to bore you with a lot of things, but it really helps when you're thinking about these agents to have a little background of this physiology. So there are several different kinds of adrenergic receptors. There's alpha receptors and there's beta receptors. The alpha-1, when you activate the alpha-1 receptors, you get vasoconstriction. When you activate the beta-1 receptors, that increases your cardiac contractility. When you activate the beta-2 blockers, you actually get vasodilation. Dopamine has its own receptors, okay, and you're probably familiar with the agent dopamine. I'm sure you use that or have used that. That affects several receptors. There's receptors in the renal circulation, the mesenteric circulation, actually in the coronary and cerebral circulations as well. When the dopamine receptors are activated, it actually causes a little bit of vasodilation. So, when we talk about low blood pressure, when we talk about shock, we also want to think about there's different kinds of shock, right? You can basically be hypovolemic. You have a low intravascular volume, okay? That can happen because you're dehydrated is kind of the layman's term for it. That's not really an accurate term for it, but or you can have blood loss, for example. Okay, so always remember when you're treating low blood pressure, always remember the component of volume, and we'll get back to that. Or your blood pressure may be low because of pump failure. Okay, your heart is just weak. You're not providing enough cardiac output. That's pump failure. Okay, is a way to describe that. You can also get some other situations where, the heart may be pumping away, but your blood pressure is still low, and that can be because there is a failure of your system to maintain that vascular resistance. So, and it's like a maldistribution of blood flow. Blood can pool in the veins. Sepsis, for example. Okay, if we were to measure these numbers, if we were to measure the systemic vascular resistance in someone with sepsis, their cardiac outputs can be very high, but their systemic vascular resistance is in the toilet, and that's why their blood pressure is so low. Anaphylaxis is another one of those situations where you just get incredible systemic vasodilation. And there's some other neurogenic causes of that too. But so basically think about volume, think about pump, but think about other things that may be affecting the systemic vascular resistance more directly. So when we talk about these agents, and we're going to go through several, and this is why I went through these adrenergic receptors, think about different things. Many of these drugs affect more than one receptor. There's a dose response curve for something especially like dopamine, for example, and we'll get back to that. There's direct versus indirect effects, okay, and we'll get back to that too. Never forget volume. Okay, let me say that again. Never forget volume, okay? And the other thing we always comment on is just in terms of using these agents, because some of them are potent vasoconstrictors. For long-term use, we want a central line, but for short-term use, we can certainly get away with a peripheral line. So let's start off with some of these agents. So the first one I'm going to talk about is norepinephrine, trade name Levophed. I'm sure you're very familiar with that. That is a very potent vasoconstrictor via alpha-1. Okay, that's its most prominent effect. It's got a moderate effect on cardiac inotropy. Okay, so cardiac contractility, so beta-1. You can actually get a reflex bradycardia from the increase in the mean arterial pressure, and that's what I mean when I talk about indirect effects. And sometimes those indirect effects can be helpful, and I'll get back to that when we talk about neosynephrine, for example. So that's a indirect effect. The direct effect is that you're raising the blood pressure. The indirect effect is sometimes it can slow the heart rate down. But again, it is a beta-1 activator too, so it is going to speed the heart rate up most of the time. The norepinephrine really is our preferred agent for septic shock and probably for cardiogenic shock as well. I think we probably don't use it enough. I know in my career I tended to use dopamine a lot, and I'm not really sure why. That might have been an institutional thing. Maybe I was afraid about because I only had a peripheral line or whatnot. But ultimately, Levoped's probably going to be more effective in raising your blood pressure than dopamine, for example. So, and again, we don't need to get into huge details about this. I put it in there just so you can kind of think about things. But typically, we would start at a rate, if we were giving an intravenous drip, of somewhere around 5 to 10, 8 to 12 mics per minute. And we can go up to much higher doses. Like all these agents, obviously, it's diluted. And because we want to avoid local effects in that peripheral vein that we're giving it in. Does that make sense about norepinephrine? Okay, good. So the next agent I want to go to, and I think you guys have access to this, is what we call phenylephrine or neosynephrine. So that's a very different agent. Okay, it is purely alpha-1, and that's beneficial in a lot of circumstances. So with the alpha-1, it's pure vasoconstriction. It's a pure vasopressor. We're not going to have any of these other beta effects, so there's no effect on the heart rate, which can be very beneficial. And in fact, like some of these other agents, when you increase that blood pressure, you can actually get a reflex decrease in heart rate, which can be very beneficial because when you're going up on these agents, patients often get tachycardic, and that can cause problems of its own. So it can cause a little bit of a reflex bradycardia. Again, in the wrong situation, we may increase systemic vascular resistance, but that may be at the expense of the cardiac output. And that's something that you're not going to know, without monitoring, obviously. But the point I make is neosynephrine is an agent I often turn to when I have somebody who's hypotensive, they're in AFib, they're going fast. Yeah, you could give Levoped to that patient, you could give dopamine to that patient, but if they're already going 150, you're not going to be real excited about that. You may get yourself in a situation where, because of that heart rate going so fast, there's not enough time for the ventricles to fill, your stroke volume goes down, your cardiac output actually goes down rather than up. Okay? And that's certainly a situation when you have somebody with AFib, because you're losing that fuel injection from the atria. And so people who are going 150 in AFib, their cardiac output would probably be less than if they were going at 90 in the normal rhythm. So it's very helpful with rapid AFib, or if you're, as I say, you're going up on these other agents and you're getting tachycardia, you're getting arrhythmia, then it's a nice add-on agent, okay, because it gives you that pure effect. It doesn't have any of that beta effect. So a good agent, and we use it fairly often. I use it a lot in the cath lab. I usually do it in a bolus. We're in the cath lab and we've just given people a dose of nitroglycerin and they drop their blood pressure, and you know what, I give them 320 of IV Neo and it brings their pressure right up. Okay, I use that a lot. So typically start at about 100 to 200 micrograms per minute and can go up higher than that. Again, frequently use boluses. I rarely give a bolus that's less than about 320 just because it comes in the cath lab, it's mixed in 80 micrograms per milliliter. So I just have them give them 4 milliliters and they do well with that. So a very useful agent, and I think you guys have access to that. Is that right? Yeah. Okay, because we'll go through some of these case studies and it comes up. So the next thing I want to talk about is good old epinephrine, adrenaline, okay, the classic adrenergic agent. Its most potent effect is actually on beta-1, so it's going to speed up that heart rate. It's going to increase the cardiac contractility. It has a moderate to potent effect on the alpha-1, so it is obviously a vasoconstrictor, but it also has a moderate beta-2 effect, which is a vasodilator. So those two can offset each other. So at low dose, what you're mostly going to see is an increase in heart rate, hopefully an increase in cardiac output as well. That beta-2 effect can offset that alpha-1 effect. That vasodilation can offset the alpha-1 vasoconstriction. So you're going to get a variable effect on the systemic vascular resistance and a variable effect on the mean arterial pressure. At the high doses, though, fortunately, the alpha-1 predominates. So if you keep cranking up on that, hopefully you're going to get an increase in blood pressure. Epinephrine is actually the treatment of choice for anaphylaxis. Okay, and the way I remember that is it's got a pretty good beta-2 effect, and if you've got somebody who's anaphylactic and they're wheezing, you get a little bit of beta-2 effect as well to cause some relief of that bronchospasm. That's kind of the way I think about that and remember that. Epinephrine has often been added to norepinephrine drips for treatment of sepsis. Again, it can cause some tachyarrhythmias because it's got a good beta-1 effect like we talked about. It does, you don't want to have people on epinephrine for too long because then you can get vasoconstriction in your intestines and you can start that can lead to intestinal ischemia and loss of bowel. But if you need it, you need it. Typically we start very low, about microgram per minute, and can go up much higher than that. Dopamine, okay, I don't know if you guys, do you guys have access to the dopamine? Okay, good. So this is the one where you really have to think about the dose response curve. Okay, this is really the agent where this comes up most. At very low doses, in a range of 1 to 2 micrograms per kilogram per minute, so a very low dose, you're really just hitting the dopamine receptors. And so you're actually going to get vasodilation and a decrease in your blood pressure. Okay, and that's typically why when we have somebody on a dopamine drip and we're tapering it down, we don't taper it down to 1 to 2. We don't taper it down to a really low dose. We get down to a little higher dose and then just stop it because as that dose goes down, you might have some transient hypotension because you're just hitting the dopamine receptors. At a medium dose, 5 to 10 mics per kilogram per minute, the beta-1 starts kicking in and it has a little bit greater effect on the cardiac output than the heart rate. More than 10, the alpha-1 predominates. So that's why if we're hypotensive, we're cranking up that dopamine to higher doses. Again, just be aware of that. If you're going to use it for hypotension, don't be afraid to give a good dose. Okay, that's important. Same thing. So typically, I'll start it in the cath lab probably at about 5 mics per kilogram per minute, something like that, and work my way up. It's an alternative to norepinephrine in sepsis, as I mentioned, especially if you've got systolic dysfunction or bradycardia. But it tends to have more adverse effects than the norepi. Again, tachycardia, arrhythmias at higher dosage, and probably less effective overall on the blood pressure. And this is why, as I say, in general, for sepsis and cardiogenic shock, levofed's probably our best agent. I'm just going to throw in a little bit about something called dobutamine. You probably don't have access to this, but you do. Okay, so you may see it from time to time. That's really an inotrope. It's not really a vasopressor per se, and so you generally wouldn't use that in sepsis, for example. Okay, in sepsis, as we talked about, the problem is not the cardiac output. Cardiac output can be very high. The problem is the systemic vascular resistance has fallen in the toilet, and that's part of the reason why the cardiac output is very high. But it does have a beta-1 effect, so it will increase the heart rate. So it can be useful in heart failure, for example. Okay. It really doesn't have an alpha effect of significance, but it definitely has a beta-2 effect. So it can cause a vasodilation. And again, sometimes that's good. People who are in untreated heart failure because of their low cardiac output, often the body tries to maintain that blood pressure by increasing the systemic vascular resistance, which again kind of fights against, the heart has to work harder, right? So in heart failure, if we can lower that systemic vascular resistance a little bit and increase the cardiac output, that's a good situation. And so you'll often see dobutamine used in that situation. But again, the overall effect on that blood pressure is going to be variable because it really just depends on that relative effect on the systemic vascular resistance. So agent of choice in low output cardiac CHF with reasonable blood pressure like we talked about. You can certainly add it on to agents in sepsis if the cardiac output is actually low. That's a little unusual. This is also dosed at a microgram per kilogram per minute. Dosage, start low, work our way up. So it's an inotrope. It's a little bit of a chronotropic agent in the sense that it increases the heart rate. Its most prominent effect is the beta-1 effect, so that's going to hit the heart rate and the cardiac contractility, but it also has the beta-2 effect. This is an agent where sometimes we will use it when we feel like the hypotension is not due to other issues, but it's related to the heart rate is so low. If you need to do something to get the heart rate up, this would be a good thing to use if atropine doesn't work. I just threw this in. This is kind of ancient history. Arginine, vasopressin, AVP. We used to use it in ACLS protocols. It's not in there anymore, but it's a pure vasoconstrictor. Sometimes we will rarely see it in the CVICU where they're using it in patients who are on multiple drips and still hypotensive after heart surgery. As I said, that's mostly kind of a relic. But if you're reaching for some other agent, there's another agent out there. All right. I went through that kind of fast, I realize, but does that make any sense? So what agents do you typically use most often? Of the ones we've talked about, which agents do you typically use? A lot of Levophed.
We use push dose for neosinephrine and epi push dose.
Okay, good.
We're trying to buy some time.
Good, good. And those are good ways to go. All right, so I actually had somebody provide me with some case studies that I think illustrate some of the principles, so we'll go through those and just take our time. So the first case was a 34-year-old woman who was actually had to be transported down to MUSC from Oconee, and she had a very complex medical history. She's had a renal transplant, but she's on hemodialysis. She had the equipment malfunction with the hemodialysis. She'd recently been admitted for heart failure and pneumonia and cyanoid AMA, and on top of all that, is pregnant. There's a history of tetralogy of Fallot. I'm not sure where that really fits in. And there was concern for hemodialysis catheter infection. So your job was to transport her to MUSC and get there safely. She was short of breath, tachypneic. Her lungs were actually clear, although her sats were low. That's a little curious to me. So it didn't sound wet, but her sats were low. So that makes me wonder about a couple other things. She was given some IV Lasix nonetheless, some magnesium and some antibiotics. I'm sure they were worried about infection. Unfortunately, there was no fetal heartbeat or fetal movement noted. Her white count was elevated. Her platelets were 16,000. Her prothrombin time was up. Okay, and you see her BUN and creatinine. So with those kind of numbers, I start thinking about things like DIC, for example, disseminated intravascular coagulation, and that can be related to fetal loss as well. But she was given propofol, intubated. Her SATs came up. Her initial blood pressure was 107/75, heart rate of 135. After intubation, her blood pressure fell, and her heart rate went up a little bit. Propofol will stop. Propofol is not an agent that typically causes a lot of hypotension, but they must have been concerned about that. So they changed gears a little bit, went to ketamine and fentanyl, started Levophed, 8 mics, which is a reasonable dose, went up to 40, gave some fluid, and a neo bolus of 80, and ultimately she made it to MUSC. So success. Okay, success. So what do I take from that? Well, again, there's a concern here for infection or sepsis. Keep that in mind. The concern, as I mentioned, for DIC, the fetal loss and some of those numbers really suggest that to me. In the settings of clear lungs, but hypoxia and tachypnea, I don't think heart failure is not the first thing I think of. It could be pulmonary embolism. It could be a number of other things. So keep that in mind. I'm not sure where the tetralogy of Fallot really fits in, but as I said, Levophed overall is a good choice in most situations, and that was the go-to agent here, and that obviously succeeded. But again, if you've already starting at a heart rate of 130, 140, be careful about that. Okay. Volume, volume, volume. Make sure that you've got adequate fluid resuscitation, even if there's cardiac issues. You never really know what's going to happen to somebody when you give them fluid, because you don't know where they are on what we call the Starling curve. Okay. The cardiac output, the stroke volume for each individual beat, is dependent on the initial filling pressure. Okay. What's that patient's fluid status? If you have a very stiff ventricle, okay, your filling pressures may be a little bit high, but they may not actually be enough for you. You may need to have even higher filling pressures to generate a good cardiac output. So you really never know what the ultimate result is going to be in terms of the cardiac output and the blood pressure until you actually give the fluid. Okay, and again, this is someone who is intubated. Their lungs didn't sound wet, so you have a little room to move there. Okay, don't be afraid to give fluid in that situation if you need to. Okay, they gave her a little bit of fluid, not a lot, but a little bit, and that seemed to help. The other thing I'll just mention, and again, you probably already figured out that neosynephrine is a favorite of mine. That's a good agent to use if your blood pressure's low and your heart rate's already high. Okay, 80 milligrams I think is kind of being a little too wimpy. Don't be afraid to give a bigger dose. Okay, so don't be afraid to give fluid if you need that, especially you're in transit. Your job is to get them there, right? And you got to maintain the blood pressure. The patient's already intubated. You don't have to worry about. Hopefully, you don't have to worry about them decompensating too badly as you transport them. You need that pressure though. You need perfusion of the body. So remember fluid resuscitation. Even if there's potential cardiac issues, we can always take it out later, hopefully. And don't be afraid to be aggressive with the dosing of the neo. You know, I don't know how much 80 micrograms is going to do. So think about higher doses in that situation. All right. Any questions about that case? Does that make sense? Okay.
I have a question,
Yeah.
actually. Like when you consider like cardiac anomalies, you know, that
Mm-hmm.
came at birth, really, and then you just wonder what is that patient's, you know, EF, especially when they're a renal patient, they've had history of
Mm-hmm.
failure, and all those things. I didn't run this call, but I did discuss it pretty at length with the crew, and so I guess the question is I think there was a lot of concern about, you know, what was the EF?
Oh, yeah.
What was
Yeah,
the
yeah, yeah.
ability- And if
Oh,
the more fluid you gave,
Right.
you know, are we going to be able to keep up with that then?
Right.
So,
Right. And although and
I'm
I.
just curious.
Yeah,
about that.
and I understand those concerns, but this gets back to what I said before. Even you know, and it's hard. It's a little unsettling to give the fluid blindly like that. It's a lot easier when you have them in a situation where you've got a pulmonary catheter in, and you can see what their filling pressures are. What we used to do was, and again, the other way I think about some of these numbers, and this is kind of getting away a little bit from what you're talking about, but when we have them lined up in the hospital, okay, someone's in heart failure and we line them up, and we shoot the numbers, okay. I know what their right atrial pressure is. I know what their wedge pressure is, okay, which hopefully is related to their left ventricular filling pressure. So we know what their filling pressures are on both sides. We know what their cardiac output is. We can actually sit there and calculate their systemic vascular resistance. I mean, we can actually get these numbers that I'm talking about. And a normal wedge pressure, okay, in a normal person would be, say, less than 12, okay? You might have somebody who has chronic heart failure, whether that's related to a low ejection fraction or a preserved ejection fraction. They may walk around with a wedge. You know, they don't have a wedge. They don't have a PA catheter in. But if you were to measure that, they may walk around that being 20 all the time. Okay, and their body adjusts to that a little bit. The lymphatic drainage increases a little bit, and so they're not walking around in pulmonary edema all the time. But the reason they're walking around with that pressure is if they don't have that filling pressure, then that ventricle it's a stiff ventricle, whether it's dilated and hypokinetic or it's not, it's a stiff ventricle. They don't generate enough stroke volume. Okay, so the point I'm trying to make is those pressures are a little bit relative. Okay, if we were measuring those absolute numbers, and there's all sorts of ways where, you know, where are you putting the transducer? You know, if you move the transducer up and down, it's going to change those pressures a little bit. What really counts is, listen, you know, maybe this patient has a wedge of 20. Maybe they're going to do better in terms of cardiac output and systemic vascular resistance if I bring their wedge pressure up to 24. We only know that if we try it. Okay, when they're lined up in the hospital, you can do that. Okay, I mean, we literally would do this. We would give them a bolus, and then we'd shoot their numbers again. And if those numbers were heading in the right direction, good to go. If it was heading in the wrong direction, we say, hey, we got to head the other way. Now, you're talking about operating in a blind situation, and you don't have the access to that, and I get that completely. But my point is, you know, you've got to get that patient to you have to get them to survive that flight, okay? And if you're really struggling with blood pressure and someone who's intubated, and it doesn't sound like there was overt pulmonary edema from what limited history we had, okay? All I'm saying is, we have a little wiggle room there. I'm not saying give them 5 liters. That's not what I'm saying. But we got a little wiggle room, and don't feel too bad about
So in
giving
this
some
case,
fluid.
would you have suggested, I mean, mean, I guess that's where we're looking for the extra guidances. Like, you know, would you have suggested, you know, a 20 ml per kg bolus because of the sepsis situation and everything else you had going on? Would you have given a little more fluid based on that?
You know, and again, I don't get me wrong. I don't mean to Monday morning quarterback.
No, but I mean,
okay.
this helps us.
Right, but
you know.
but in retrospect, yes, I think if you're hypotensive and your heart rate's 140, and you've got somebody who's intubated and their SATs are okay, yeah, I would give them a little more fluid. Okay, I definitely would do that.
So I was on this call. It was kind of it was crazy.
Yeah, and this lady's very complicated.
Well, so you started out with the Prehospital, which killed the pressure. So that's kind of why we went with ketamine to kind of boost the pressure. But then you're looking at the 140 heart
Yep.
rate, which that always screws the heart rate up.
Yep.
Well, we were having a lot of difficulty getting any help from any medical direction. The sending told us to just get out of there.
Right.
And then
And I got that impression, I think, from yeah.
yeah, he was
Yep.
like, y'all need
Yep.
to leave. And
Yep.
we're
Yep.
like, there's a dead baby in this woman, and she's
Right. Right.
doing really bad.
Right.
So then we called MUSC, got no direction whatsoever, and we're like sitting here. The only tool that we had really was the Levophed, because they were like, it's better on the heart rate.
Right.
than
Right.
everything else.
And there's absolutely nothing wrong with Levophed. Don't
Well,
get me wrong.
We were just kind of like, all right, our pressure's in the can the entire flight. She was hypertensive or tachycardic the entire time, so that's why we went with fentanyl. Just like,
Right.
maybe she's hurting somewhere down deep in there.
Right.
So like we were trying all these things and nothing was working. And she died like 6 hours after we got there. I mean,
Yeah.
she made it, thank God, with us. But
Right.
then she like died.
Right. Right.
shortly
Not surprising.
So we were just kind of like, all right, where do we go from here? Because really, all we have we were maxed out on Levophed.
Right.
We did want to get fluid because what else do we have?
Right.
At this point?
Right. Right. And that's what I'm
Then
saying.
we were like,
Right.
you don't want to flash, and then
Right.
I mean,
Right.
we were just like, what other options? Because we don't carry Neo. So listening to this lecture, that would have been helpful. 'Cause
Right.
All we had was the.
But it sounds like she got some Neo.
She got push doses.
Right. Which
That I mean.
is fine.
a drip would have been
Yeah.
helpful.
Yeah.
But we
I
had that, so like in our toolbox that we have
Yeah.
with us in the
Yeah.
air, really we have
Yeah.
dopamine. We could have mixed an epi-drip, but both of those we thought would mess with the heart rate still.
right.
So we
Right.
felt all we had was Levophed. So just kind of wondering,
Right.
was that all we could do?
Right. So and let me take your.
Did they have, and I'm wondering, with the blood pressure, did they have a fibrinogen on her with an elevated PTT? PIC, like, would,
You know, I don't remember.
There was no.
I don't remember.
That was the direction we got from MUSC.
Yeah.
I was on the flight with it.
Yeah.
That was the direction we got from MUSC was, it was a resident who was attending was putting somebody and said that he was like, get a fibrinogen and see if you need cryo. And so we suggested it.
Right.
And the attending was like, yes,
Right.
that's my option.
Right. And again, I've obviously edited the transcripts here, right? So, and I get that. So I appreciate completely the situation you're in because, but this is what I'm saying. You know, your job is basically to get that patient there.
Yeah.
And you succeeded. I mean, the patient ended up dying 6 hours later, and I was wondering what happened. I'm glad you provided some follow-up. But whatever you did, you succeeded. The fact that you can't mix up a Neo drip, that doesn't bother me at all. I mean, that's fine. You just give repeated boluses. I mean, I'm fine with that. But my point on that is don't be too wimpy with the Neo because you're not going to hurt somebody with Neo. It's hard. It may not work. It may not help you, but you're just not going to hurt somebody with Neo. Because you're not going to get that tachycardia. If anything, if we can get a little control of the blood pressure, that heart rate may come down a little bit on us. So, like I said, I never use anything less than 320. I mean, some of that's a matter of convenience. And if you have to keep giving boluses of 320 every couple minutes or whatever works, right? It's nicer to have the drip, obviously, but whatever works. So,
We just wondered, is there anything in what we had that we have done differently? Because it was just chasing the tail.
right? No, I don't. Like I said, I'm not trying to Monday morning quarterback. I'm just.
Listening to your lecture,
yeah.
it seems like Neo might have been
Yeah.
the most helpful.
Neo, again, and you've already said this a couple times. I'll say it again. It's a favorite of mine. To me, it's like It may not help, but you have little to lose with it. So just be aware of that. Kind of get, I don't know if you were wondering about the tetralogy of flow or not. I suspect that probably doesn't play a big role in that. You know, the tetralogy of flow generally affects the right side of the heart, and so the left ventricle is generally not affected. That doesn't mean the right ventricle couldn't be affected. And that can have implications, obviously, for your blood pressure, too, in the extreme circumstances. But I doubt that was that she had much bigger fish to fry than that, I think. So.
Definitely don't think that we're experts in congenital heart.
Right,
heart defects. So,
and nor should you be,
hear
yeah.
one congenital heart defect, and you're thinking,
Right.
well, how many surgeries did
Right.
that take to fix?
Right.
So what's
Right.
the state of the heart baseline, right?
Right,
So
right,
I guess
right.
that's
Just
probably what we're thinking.
for your future reference, if you've got repaired tetralogy of flow, the issues in those patients are, again, going to be all right-sided. Depending on how the repair was done, for a long time, they basically just, the tetralogy of flow, part of the problem with the tetralogy of flow is stenosis of the pulmonary valve. And they basically would just take the pulmonary valve out. And so you'd have this wide open insufficiency, which the right heart tolerated fairly well for a good amount of time, but then ultimately the right heart would dilate, and then you start to get arrhythmias, and you start to get all these other things. That's the typical story. These days, they're much better at preserving that valve, replacing that valve, and so you don't have those kind of problems down the line. But that's just a short zinger on tetralogy. All right, any other? That was a great case, and like I said, success in very difficult circumstances. So you should be proud of that. So good. All right. So the other cases are not quite as involved as that, but let's just go through a couple other ones. So case number 2, 55-year-old female, cardiac arrest, pulseless, apneic, intubated. The rhythm was asystole. You get this history of alcoholism and hypertension. Got an interosseous line started. I love those. It just amazes me that those work. A bunch of epinephrine, absolutely. A good bolus of fluid, absolutely. Blood sugar was 24, given D10. Blood pressure came up. Did get return of circulation. Sinus rhythm, EKG suggested a prior anteroseptal infarct, nothing major, but no acute changes. Initial blood pressure was 52/47 with a heart rate of 77. That's kind of funny. I'll get back to that. SAT was 82%. So actually got an IV line, gave more fluid, great. Gave an epibolus, 10 micrograms. Started with dopamine at a good dose, up to 20. Then added levo, again, good dose. Patient ultimately expired. So what are my thoughts on that? Okay, just a couple things. First of all, it's a little weird to have a blood pressure of 50 and a heart rate of 77. Something's going on there. Okay, either the patient is super, super sick and is about to die on you, which maybe that's what it was, or there's something vagal going on, or there's something else going on there. That's weird. That's not physiologic by any means. And there might have even if you had beta blockers in the system, I'd be a little surprised that the heart rate would be that low. So think about atropine in that circumstance, by the way. Okay, again, you have little to lose. It's not the typical thing when you come across somebody who's asystolic, but I would just think about it. I'd just throw that out. The dopamine is reasonable, but like we said a couple times, the Levoped's probably a better initial choice, especially when you're not worried about a fast heart rate in this person. You're actually worried about a relatively slow heart rate. So I probably would have thought about Levoped. Since you have that as well, I probably would have thought about that. The other thing, and again, I'll make the same comment about the epinephrine that I'll make about the Levoped. This person's dead. Don't worry about your epinephrine dose. I mean, don't be too wimpy about the epinephrine dose. I've had the occasional patients, they anaphylax on you in the cath lab because they're allergic to contrast, and they look like crap. And I'm going to give them a milligram or two of epi. I'm not going to give them 10 micrograms of epi. So be more aggressive. Again, you can't hurt this person. You might help them. You can't hurt them. So give more epinephrine if you need to. Don't be hesitant to do that. That's all I say. This person, no matter what we did, was probably not going to survive. But Just think about that. And again, that just kind of reminded myself here, why do we use epinephrine in codes, by the way? I mean, why do we bother doing that? And what's the ultimate purpose? So the ultimate purpose is, I mean, you're trying to get a blood pressure, and the reason you're trying to get a blood pressure is you're actually trying to maintain perfusion to the vital organs, okay? And by vital organs, we're talking about the heart and the brain. If the kidneys get ischemic for a couple hours, you know what? They'll survive it. If the legs get ischemic for 4 or 5 hours, guess what? They'll survive it. Your brain and your heart won't. So, you bring that up, and you've got to get that pressure up because you're not perfusing. If you're not perfusing the coronaries and the myocardium and you're not perfusing the brain, all you're doing is for naught. So I just throw that out there. Sometimes we forget about that. The other, and it wasn't not applicable to this case, but the other reason we use the epinephrine is it seems to help. When you've got somebody in VFib, you're going to have more success after a shock with epi on board than without the epi. But that's kind of that didn't apply to this point, this case. All right. Does that make sense? Good. Okay. So don't think about atropine. Think about it being aggressive in terms of not only neo doses but epinephrine doses, and Levophed in general. Okay. Case number 3, 64-year-old female. She syncopizes on the sofa when EMS arrives. She's lethargic, hypotensive. And then you get the story and say, okay, I think I know what's going on here. So she recently signed out AMA from the emergency room, where they wanted to give her some intravenous fluids. She declined. She's got a history of cancer, probably doesn't have good PO intake. Getting some IV fluids almost daily because of that. There's always a question of a UTI, right? There's always that question. Lung sound junkie. I'm not sure what kind of cancer she had. I suspect it was probably lung cancer, but I'm not sure. Initial blood pressure, 58/45, heart rate of 108. So large raw IV started, fluids given completely appropriately. It sounds like this lady just gives you the story. It sounds like we got hypovolemia for sure. Again, 10 of epi. Again, you probably could do more, but this is a little different from the previous patient, right? This patient is actually alive. So if you want to be gentle with the epinephrine, I'm fine with that. Started Levophed at 5. That's a very reasonable. Antibiotics because of the concern of infection and other things. So the only take-home point I would make from this particular case, because I think it was again, I'm looking through the retrospectoscope, but reading the history, it really sounds like this person was really hypovolemic, and that was part of the problem. So even though lungs sound junky, that could have been bronchitic for all we know. So don't hesitate to give fluids. Inadequate fluids were given, by the way. There was LR and normal saline. So good job there. All right. Any questions or comments on that one? I think we have maybe one or two more here. Let's see. So case 4, 73-year-old male found unresponsive by his wife. Recent diarrhea, decreased PO intake. Does have a history of COPD. Is on oxygen chronically. Has a fib, has a pacer, has had cabbage. This guy's got everything. Glucose of 244. Initial blood pressure 56/36 with a heart rate of 24. So what's going on there? Next blood pressure 69/34 with a better heart rate of 72. Lungs were clear. Temperature looks like hypothermia. So given a liter, absolutely. Epinephrine, low doses, but frequent, that sounds good. Antibiotics, intubated, Levophed with recovery of pressure. Good. So again, my point, fluid. And the other comment I would make, you just kind of wonder if someone's got this heart rate of 24, is that real? If it's real, then his pacemaker wasn't working. And sometimes that's because the battery's dead, but sometimes that happens, if the myocardium is so sick. I mean, this is why sometimes, people, families of patients who are in the hospital and they're dying, and they're DNR, and families will come to us and say, can you turn the pacemaker off? It's like, guess what? I don't really need to turn the pacemaker off because it's going to become irrelevant. you're going to see a pacer spike, but there's not going to be any capture because the myocardium is so sick, or the patient's so acidotic, or they're so hypoxic, that doesn't matter that the pacer's, it's not going to do anything, so don't worry about that. We don't need to turn it off. Nature will take its course. So it just made me wonder about that. All right, I think we have one more. Any questions about that last case? Yeah.
Just about the pacemaker, if you see that, would you consider bicarb, something like that, just in case of the acidosis?
Yeah, I mean, I would do, the typical things, absolutely. Yeah, and if we were to get a rhythm strip, we'd get a little better idea what's going on there. Are we even seeing pacer spikes or whatnot? But yeah, if that's what the issue is, then again, that would be a situation where I would, like I mentioned in that other case, give some atropine as well, by the way. But yeah, giving an amp of bicarb is unlikely to hurt somebody too. I think that's not at all unreasonable. All right, so case 5, a 29-year-old male. Boy, I read some of these cases just like, oh my God, I can't believe you guys do this. Self-inflicted gunshot wound to the head, through and through at the temples. The pupils are fixed and dilated. There's no gag reflex. Patient was intubated, bleeding, and when that happened, they were bleeding from the airway as well as the head. Just a great case. Blood pressure, no surprise, 97/86, heart rate of 140, SAT of 90, given 10 of epi. So the comment I would make there, and they're not all necessarily applicable to this particular case, but obviously think about hypovolemia, like we've said over and over and over again. I don't really treat brain trauma patients, so I can't really speak to this directly, but I wonder if there was some component of some neurogenic hypotension there. That's not the typical scenario where you see the neurogenic hypotension is when there's some kind of spinal cord injury, because then that interrupts the autonomic nerves that control the systemic vascular resistance. And that's not exactly what happened here, but it just made me wonder. This intracranial hemorrhage leading to increased intracranial pressure, probably not an issue in this particular patient because there were exit wounds, entrance and exit wounds, so there probably was not increased intracranial pressure. But when you do come across that possibility, typically what happens with those patients actually, if there's not any other things going on, they typically get hypertensive and bradycardic from increased intracranial pressure. You may have seen that. So if you got bradycardia, you can obviously treat with atropine. Fluids in neo, since the patient was so tachycardic, that would have been my thought. Good. Okay, I think that's it. Any questions on that last case? Okay. All right. Any questions in general?
Somebody wants to know what's the best push dose pressor for an acute STEMI going to the cath lab?
Push dose. I think, and again, given what you have, so you have access to Levo, you have access to Neo. What else is an epi? Part of that depends a little bit on what the heart rate's doing. Okay, if they're tachycardic, then I would go with Neo. That would be my best bet. If they're not terribly tachycardic, and we're not really used to using Levo as push, but if that were your only option, then I probably would think about using it. Well, yeah, I guess I would try that. You're not configured to give the Levo really as a bolus, so that would be a little funny. But you are configured to give the epi as a bolus, so I guess I'd probably go with the epi bolus. If you had to give something bolus, and that's what the question said. So probably if the heart rate is not terribly high, then try the epinephrine at low doses because you got a conscious patient, and you don't want to provoke arrhythmias in a patient who's already ischemic. So you have to be careful about that. That's why I like the Neo, but especially if the heart rate's high, the Neo would be a good way to go. Okay.
One more. So if you have a post-arrest, got them back with epi, are you thinking epi drip or levo drip, or like you said, just depends on the rate?
I have used epi drips. I probably in that circumstance, Just because I'm a little more familiar with the Levofed dosing, I probably would do a Levofed drip. And then maybe give some epiboluses on top of that if we needed to. That's probably the way I would approach that. Yeah. But yeah, and again, some of this is just related to that, you don't have Levo as a bolus, right? And so we typically use it. But I remember a case I had that I was basically trying to find a way, it was a STEMI, and I was trying to find a way to get in this guy's artery somewhere. I couldn't feel a femoral pulse, and they might have had some peripheral vascular disease history too. I ended up going brachially, and even that I had a hard time feeling. I had them give him 3 milligrams of epi. I could feel a pulse. I got in. I mean, you do what you got to do. I don't think, but he was one of those circumstances where, yeah, after the epi wore off, his blood pressure started trending down. But at least I got in. I got enough pressure transiently to do what we needed to do. So, yeah. Okay. Anything else? Any other questions? You can sideline me later if you want to. That's fine too. All right. Great. Thanks. Thank you for doing what you do.